And then we're going to go through the actual device. So we're going to meet the CARDIOSAVE balloon pump, and then we'll do some questions at the end. So on the history of balloon pump therapy in the 1950s, they explored the concept of diastolic augmentation and looked at some designs and the assembly of a pump itself. And in 1978, there was a 12-French catheter that was inserted via an actual surgical cut down. And that was the first balloon pump therapy that was used. Now, over the years, we've gone miles in terms of reducing catheter size. And in fact, making the balloon pump itself a lot more friendly. In the very first balloon pump insertions, literally take a patient to the room where the balloon pump was.
Samantha. Hey, Samantha, go ahead. Leon, did you mute Samantha as well?
Can you hear me now?
Yes, I can hear you. Thank you.
Good. So just an indication of how far we've come from these enormous pumps that were in a particular room. So the balloon pump patient would need to be taken to the balloon pump room, and that's where the therapy would then be applied, to where we are now in terms of these tiny little transport units that weigh less than 25 kilograms. So that's where we are just in terms of the timeline that you can see there. So in 2007, fiber optic technology was introduced, and that in particular has made an enormous difference in terms of delivery to the patient of the therapy itself. So that's a little brief history of the balloon pump therapy. Okay, so if we can just go through a little bit of anatomy and the actual circulatory system so that we can understand exactly where the therapy fits in, why it works, and really just the basic, very simple concept of counterpulsation. It really only achieves two things, and that's where we'll go through it. Okay, so you guys know this diagram because it's something that Antoinette draws often. And it's a nice diagram to just explain exactly how things work. So if you can see my cursor, I'm just going to take you through it. So what you see here is an extremely crude, my drawing, my handwriting, so apologies for how awful it looks, but it'll make more sense when we go through it. So what you have here is a crude diagram of the four chambers of the heart and the circulatory system. So if we have a look here on the right side of the heart, we've got from the inferior vena cava and the superior vena cava, we've got our deoxygenated blood, or our oxygen poor blood, should we rather say, that comes back to the right side of the heart. And this collects here in the right atrium, and that's just before where you would measure your mixed venous gases, and that's the type of gas and analysis that you would take from there, from your CVP line. And if you can see there, so collecting in the right atrium there, it falls through this valve over here, which is your tricuspid. It is then ejected here by the right ventricle up to the pulmonary arteries. And that's going to go through to the lungs, where you're then going to have oxygen added and you're going to have CO2 removed via gaseous exchange. Then it's going to come back to the heart via the pulmonary veins. That's going to collect here in your left atrium. That's going to go through your bicuspid or your mitral valve. And then that's going to collect here in your left ventricle. And then that's going to be ejected then here via this huge vessel, your big aorta. And that's what you see there. So if we drill a little bit further down into my diagram here, I've drawn in a balloon catheter there. And you can see it's got a little tip to it over there. And that will need to be placed 1 to 2 centimeters distal of the subclavian that we've got here. And the balloon will inflate from here. And what that would then do is we've got a collection of blood, oxygen-rich blood here in the aorta that is in the arch. Where you have a patient that needs additional coronary perfusion, so let's say that patient needs a heart bypass and they've got occlusions here in their coronary arteries, then what the balloon would do is, because the coronary arteries receive their perfusion during diastole, when the heart is at rest, the balloon would inflate in that phase in diastole, and it would at force push through the remainder of blood that's left here that would normally only go into the coronaries at a very low pressure, at almost like a back trickle, if you like. It pushes that then with force through the coronaries into the coronary arteries, and that will then perfuse the myocardium. During the systole, where the heart will actually be contracting and working, the balloon will deflate. And what happens with that deflation, the space that it was taking up there in the aorta is then miraculously gone in that second. And that deflation of the balloon creates a dead space here, almost like a vacuum. And that automatically drops the pressure here in the aorta. So that's a drop in your systemic vascular resistance there. That drop in pressure there relates to a drop in pressure here at the aortic valve. And that translates then to a reduction in afterload. So in other words, your heart doesn't have to pump as hard. The left ventricle doesn't have to overcome as much pressure to open the aortic valve to eject the blood into the aorta to perfuse the rest of the body. So those are the only two things that a balloon pump achieves. We're looking at it for achieving both of its tasks. The perfusion by it inflating during diastole is number one. And the second task that it achieves is the reduction in afterload when it deflates. And that's basically all that it does. We'll get to contraindications and indications in a minute, but that's the most important thing to remember is you've got the perfusion to the coronary muscle that wouldn't have been there because we're now inflating at a pressure and pushing blood forward, and deflating will cause a drop in pressure, and that relates to a drop in afterload or an unloading, which is specifically what you're hoping to achieve in VA ECMO, and that is all that it does. So here's your phases of your cardiac cycle. So we discussed briefly in my little drawing there, systole, so your period of contraction or work on the heart muscle, and diastole, your period of relaxation or rest. So during systole, when the balloon will deflate, you've got your reduction in afterload, which translates to less myocardial work. It will translate to less myocardial oxygen consumption because the muscle's not working as hard. That will mean increased cardiac output. So the left ventricle that was already under pressure is now able to do more because it's been assisted. And we've got a reduction then in the oxygen demand that's needed by the heart. So in diastole, where the balloon will inflate, you've got the displacement of the volume in the aorta, which augments diastolic pressure and promotes the blood flow to the coronary arteries. We've got an increase in myocardial oxygen supply because we are now perfusing the heart muscle. And that then relates to systemic perfusion because the heart is now able to work better. And we've got an increase in oxygen supply because we are perfusing. Right, so measurements of cardiac performance. This you also all know, having gone through all the training in terms of ECMO, that your cardiac output is measured by your heart rate times your stroke volume. And these are the factors that influence it. So we've got our preload, or our diastolic filling, and where we've got the fibers stretch, where the muscle in the heart starts to stretch. Contractility is the elasticity that comes back in the heart and how it's able to contract to eject. And the afterload is there translated by the arterial pressure that we were talking about. And that has an influence on your ventricle size. Right, so just in terms of the perfusion to the coronary arteries, in a little bit of anatomy here, you'll see coming off the aorta are coronary ostia. And from there is where your coronary arteries go off onto the surface of the heart. Right, so this seesaw is the supply and demand that needs to be met in a healthy patient. And when we come in with ECMO and with balloon pumps, we've got an imbalance there in terms of supply and demand. So we need to be able to supply enough oxygen through to the coronary muscle and to the whole body. And we need to be able to meet that demand. And this is where the seesaw effect comes in. Right, so let's just focus a little bit on preload. So for those of you that are looking in terms of terminology or explanations on certain things, the one that has made the most sense to me over time is the measure of actual volume in the left ventricle. So we can measure it in terms of milliliters. So it refers to the volume of blood and resulting pressure in the left ventricle at the end of diastole. So that amount of volume will then determine how much muscle stretch it relates to. And in response to the increased stretch, the force of ventricular contraction will increase as well as the stroke volume. So the ventricle needs appropriate preload in order to get optimal ventricular contraction and stroke volume. So it's that fine balance of you have to have enough preload in the ventricle in order for the muscle to stretch enough to eject. But in the patient that is having problems with the left ventricle, preload is something that you guys would manipulate in order to help the muscle and in order to help the heart not work as hard. So there's my drawing again. So here's your preload, which is measured then in milliliters. And that's then your volume of blood that would have to then be ejected by the left ventricle to the aorta. So you would manipulate this as clinicians by either giving a bolus of fluid to increase preload, or you would give a diuretic to your patient to reduce preload. In particular, in your cardiac patients, they tend to run them quite dry. Right, so afterload is the amount of resistance that the left ventricle must overcome, or the work that the left ventricle has to do to open the aortic valve. So in this example that I've drawn here, an afterload of 68 millimeters mercury is needed to open the aortic valve. So if we measure our patient's MAP and we say that in this particular diagram here, I've got a systolic pressure of 120 and a diastolic pressure of 70, then measured at the diacrotic notch here where the aortic valve is closed, that is my mean arterial pressure. And in this particular instance, I'm saying it's 85 millimeters mercury. So my left ventricle is going to have to exert a pressure of just above that, of 85, in order to open that valve and eject to the rest of the body. So if I've inserted a balloon catheter into my patient and I have reduced the systemic vascular resistance here, it translates to a drop in pressure here at the valve, so at the diacrotic notch where it's measured there, and it means that this ventricle doesn't have to work as hard to eject the volume of blood that's in the left ventricle out into the aorta. Right, so this is where you guys live in terms of ECMO and VA ECMO, is this left ventricular failure. And these are the stages in heart failure that you would come in with ECMO, and that balloon pump therapy would assist in that endeavor. In the past, balloon pump was an indication for cardiogenic shock, and it was the only device available to clinicians. And so that was what was used regularly. Nowadays, because we have ECMO available to us as a therapy, that is a better indicated therapy for your heart failure and for your cardiogenic shock. And that is where that would come in, and then your balloon pump would assist with that. So this is just a little bit of what the body experiences. So in your first phase of vasoconstriction, you've got your pumping efficiency that's reduced, your left ventricular volume and pressure that's increased, your baroreceptors are then activated, and you've got an increase in your heart rate and a release of the catecholamines, and your afterload increases and your oxygen demand goes up. In the hypovolemia stage, you've got reduced cardiac output. You've got your sodium reabsorption that's going to come in. So from the kidneys side, you've got a whole systemic process where the kidneys are now telling the body to hold onto more and more fluid. So you've got your preload that then goes up, your afterload that goes up. Your oxygen demand is going to be increased, but you don't have enough oxygen, so that's going down. Your cardiac output is going to have to go up, which it doesn't. And it's just you can see your seesaw isn't working anymore. Nothing's as it should be. Your tissue hypoxia is just pre to death here. So you've got your pulmonary edema and your oxygenation that's gone down, and your contractility that isn't there anymore, and your cardiac output that's reduced severely. Your blood pressure is dropping, and then you start to have the metabolic process that comes in, where you then have your anaerobic metabolism that comes in, your lactic acid production, your tissue acidosis, and eventually death. So that's just the stages, and you're wanting to come in stages 1 and 2, where you can start to reverse this and where you can start to help the patient. Right, so that's just a nice picture where you can see the inflation and deflation of the catheter in the aorta. Right, so in terms of ECMO, the secondary effect of the balloon pump counterpulsation and the reduction of the systemic vascular resistance and the reducing of the afterload is the major effect that we focus on in terms of ECMO, but it's the secondary effect in terms of counterpulsation. So your systemic vascular resistance will reduce due to the afterload reducing effects of the balloon. And in terms of your blood pressure, your systolic pressure will always come down. For those of you that have seen a balloon being inserted and the therapy starts, you will notice immediately that the patient's blood pressure drops. And that's due to the deflation of the balloon and the resultant decrease in the cardiac work. You will see an increase in your diastolic pressure, and we'll go through that with you guys in a minute, and with the deflation of the balloon. And then you've got your mean arterial pressure that should either remain the same or it may go up. And your diastolic augmentation, and that's your augmentation of your balloon. It's the actual balloon. When they talk about diastolic augmentation or peak diastolic augmentation, it's purely the balloon that they're talking about. There's no such thing unless you were on balloon pump therapy. Just that it won't be there. It won't be something you look for unless your patient is on balloon pump therapy. So important to remember, contraindications. If you have severe aortic insufficiency, you would not use a balloon pump. It's a complete contraindication. And the reason for that is if you were to inflate a catheter and you didn't have a working aortic valve, you are causing regurgitation. You are pushing blood back into the left ventricle when the left ventricle should be ejecting blood. So you're causing regurgitation, and you're actually increasing afterload, and you're not helping your patients at all. So that's a major contraindication. Abdominal or thoracic aortic aneurysms are another contraindication. You can think you're pushing up through the femoral artery into the aorta catheter, which you're definitely then going to cause problems with if your patient does have an aneurysm and you are pushing a catheter up through that. Then relative contraindications, you'll see number 3 and 4 here, are severe calcific aortic iliac disease or peripheral vascular disease. In most of the cases, on patients that particularly need cabbage surgery, they might in any case have that anyway. So it's, as I say, it's a relative contraindication. And the reason it's listed is if the doctor does struggle to get the catheter up through that PAD in the femoral artery, that might be a relative contraindication. But in most of your patients that suffer with coronary artery disease, they may very well in any case have already plaque build up and peripheral vascular disease. Sheathless insertion with severely obese or scarring in the groin. So we offer both a sheathed and sheathless insertion. So your relative contraindication there would be if you are opting to do a sheathless insertion of the balloon catheter in obese patients. It's due to the kinking of the catheter in the obese patients, and it's a relative contraindication. If you can use a sheath, then that falls away. Right, so In the balloon counter pulsation therapy, it's relatively simple. You need a patient, you need a pump, and you need a catheter. So what you see there is our CARDIOSAVE console. So that's the console or the pump, if you like, to which your catheter is connected. And then you need a catheter. So I've included here for you a sizing chart on our Sensation Plus range of the balloons. And that is what we refer to as our fiber optic higher efficacy balloons. And what that translates to, just to quickly explain, is that the Sensation Plus catheters are shorter, fatter catheters. So they've got a wider girth, but they don't have as much length. So you've got a greater displacement of volume in the aorta, and therefore a greater offloading by 25%. So in patients where they were small or short, if you like, so I fit into this category here, the 152 centimeter to 162 centimeter. In the past, I would have had to have had a 34 catheter, 34 cc. I wouldn't have been able to have a 40 cc. A 40 cc would have been particularly for tall patients. And had you have used that on me in the past, looking at a standard 40 cc that we do offer still in our other fiber optic range, I would have occluded my renal arteries by using a catheter like that on me. On my taller patients, we can now use this 50 cc, where everybody would normally have been wary of a 50 cc, too concerned that they might again occlude renal arteries. With this being the shorter but fatter balloon, I'm now able to use this on patients taller than 162 centimeters, and I'm no longer cut off at 183 anymore. So I can use this balloon catheter for my taller patients comfortably and safely, and I can offer them a greater offloading, and I can offer them a greater displacement of volume. So more perfusion is what it relates to for them to the cardiac muscle. Okay, so what you need is only the two sizes, and that makes everything just simpler. If you're looking at the lumen or the catheter size, you've got an 8 French on the Sensation Plus in the 50 and a 7.5 French. So if you think a little bit back on the history, it's a very small catheter. It's not chunky, so it's safe for the patient. Right, important for you as clinicians that are going to be checking and transporting patients, that you can understand where your balloon is placed, and that it's something that you know to look for on an X-ray. So if we go back just to that slide, if you have a look at what the catheter looks like, that tiny little tip in the front there, which is about 1 centimeter, and the base of the catheter are the only portions of the catheter that you can see on an X-ray. So you can see that tip, and in this diagram, or in this example, it's not great, but you should be able to see the bottom of the catheter as well. And you want to see that that is just above the renal arteries. So that's your placement. And those are your important landmarks that you'll look for. So we've gone through this briefly, but important to note that in your 1-to-1 here, you can see your diastolic augmentation. So we've got our coronary perfusion pressure that's increased, and our increase to our coronary blood flow and our myocardial oxygen supply that we know we are increasing. And here in our 1-to-2, we can see by the systolic unloading that you can notice there. So where this is an unassisted systolic, this is the assisted systolic. So this comes after the balloon here, and we can see that that's reduced versus that. And therefore we know that we are in fact unloading and we are reducing afterload. Right, important for you to just understand when you do have a patient with you in terms of timing and trigger and what's actually going on in the screen in front of you, what the pump is looking for, what the software is triggering on, and what the timing is doing. So your balloon is synchronized with the cardiac cycle. And the timing is where the balloon is set to inflate and deflate using the arterial waveform. And the trigger is the event that signifies the beginning of a cardiac cycle. So typically 9 times out of 10, we look at the ECG as a trigger, and we match that to the timing, particularly on the A wave, where we look for the diacritic notch. So at the diacritic notch is where the balloon knows that it can inflate, because at the diacritic notch, my aortic valve is closed, and the balloon will then inflate. And at the onset of an R wave, the balloon will deflate. So in the software, in the CARDIOSAVE, it would look for R wave as a signal to deflate and diacritic notch as a signal to inflate. So the hemodynamic effects of the balloon pump therapy have the most benefit when the balloon is deflated simultaneously with the start of contraction, whereas inflation before onset of diastole unconditionally interferes with ejection. So that comes back into the regurgitation that we spoke about with a leaking aortic valve. The same is going to be true as if you tried to inflate prior to the closure of the diacritic, prior to the closure of the aortic valve. So accurate timing is very important because we're trying to help our patients. We're not trying to make things worse for them. So if you have a look at this diagram here, this one, in fact, I think is going to be better. We can do this one. So one cardiac cycle is here. Then we've got an unassisted end diastolic pressure here. Our patient's unassisted systolic pressure here. This is our balloon that inflates. This is the assisted end diastolic pressure. And then this would be the reduced pressure here. So a reduction in your patient's assisted systole. So that's what you're hoping to see. And we'll go through a few diagrams here where you can see exactly why that would make sense to you. Right, so we touched on just briefly the introduction to fiber optic in 2007, I think it was, and how that has then increased the way that we can deliver or improved the delivery system of how the balloon pumps work. The fiber optic sends information back with the speed of light to the pump. So it's measured at the little tip on the catheter, and that sends information back to the pump, and the software takes back that information, and that information then helps towards the timing. So if we were using a conventional balloon with a transducer, as you all know, those of you that work with transducers, you get that drift and you're having to zero your transducer so that you're getting an accurate reading. We don't have this headache with fiber optic, and this makes the delivery system of the balloon inflation and deflation and the support to the patient that much more accurate, because it's, as I say, literally with the speed of light, that information's carried back and forth. So the algorithms in the machine or in the pump, in the software, evaluate the several key landmarks on the arterial pressure waveform to establish the timing. So our diacritic notch signifies the closure of the aortic valve, and that's one of the critical landmarks that the algorithm looks for in terms of inflation. And deflation is set prior to the opening of the aortic valve, as signified by the upstroke in systole. So that's the R wave that it looks for and where it will deflate. Right, so that's just an A wave diagram for you there. So there we've got our systolic, there you've got your diacritic notch, here you've got diastole, and that makes up one cardiac cycle. Here is when your balloon is going to come in. So if we can look at that, there's your complete cardiac cycle in A. B is your unassisted end diastolic. There it is. C is your unassisted systolic. So this is your patient. D is your augmented diastolic. So that's the difference here. Your augmented diastolic should be higher than your patient's own systolic. E is going to be your assisted end diastolic, and F is your assisted systolic. So this over here is your balloon. And after the balloon, you should have a reduced systolic and a reduced diastolic. So that's what they mean by assisted, is everything that follows the balloon is your assisted, and anything that isn't after the balloon is your unassisted or your patient. So I'm not going to live too long in terms of timing or optimal timing assessments. You just need to understand what you are looking at. And what is very important for you to know is when your therapy is on a one-to-one frequency, you cannot tell the difference between the augmented pressure, the balloon, and the patient. You can only in a 1-to-2 frequency or in a 1-to-3 frequency where you see the presence of the diacritic notch, can you tell which is the patient and which is the pump. Otherwise, it's too confusing. So the different frequencies that are available are in terms of how much support you're wanting to give the patient. But when you're looking at timing and you're trying to assess whether the delivery system is correct and whether you are in fact helping the patient, you have to move into a 1-to-2 or a 1-to-3 frequency to determine which is the patient and which is the pump, if you were concerned about timing. Right, so if we go back here and you're looking at your balloon, you need to be able to interpret the pressure waveform that the balloon shows on the pump console. And all that this is this is the balloon itself. It's not on the A line. It's on the balloon itself. It's on the console of the pump. And you need to understand, some of you may have had balloon pump therapy before where people would have referred to what they talk about, the balloon resembles a chair. So you need to understand what the different chair looks like, and you can then establish whether or not you have an effective delivery system and whether you have a normal balloon pressure waveform or whether something that you're seeing isn't correct. So we're just going to quickly draw through that for you. So there's your zero baseline. There's where the balloon inflates. That's the peak inflation. That's the plateau. In other words, the balloon is full. And that's where it deflates. So that's typically what you want to see, is that kind of a shape there. But when you have hemodynamic changes to the patient, you're going to have a balloon that looks a bit different. So if we have changes in our heart rate, there's a much longer inflation there. And that's a bradycardia. And a much shorter inflation here is a tachycardia. So I just want to go through in particular tachycardia because there's always been, when I do trainings, it's a question that often comes up, that if my patient's in a tachycardia, then I'm just going to change the balloon pump to a 1-to-2 instead of a 1-to-1, because then it's better. It isn't better. It doesn't make any difference to the patient. You changing it from 1-to-2 just means that you're helping the patient less. So what you need to do is you need to address the tachycardia in the patient, because what happens is in the very fast heart rate, your balloon simply cannot fully inflate. So you've got a balloon inside the patient's aorta that isn't inflating to its full capacity. So typically your pump console is going to alarm, and it's going to tell you that it isn't achieving the augmented pressure that you've asked it to achieve. So it automatically can see that it isn't delivering what it needs to. It also isn't fully inflating, so you've got a threat of blood clot formation on the surface of the balloon catheter itself, because the catheter has folds in it now because it can't completely inflate. So in a tachycardia, we need to address what's going on with the patient, because we do need the balloon to fully inflate and to fully deflate so that it doesn't affect the timing. The pump console uses the software that it has, and it overrides itself constantly in a tachycardia to make sure that it deflates. It focuses more on deflation than it does on inflation, because it needs to make sure that it is deflated before the onset of systole. So the pump console itself can keep up to a heart rate of 230 if it needs to. but it isn't fully supporting the patient anymore because it can't fully inflate. And that's important to note. If you're now going to just drop it down to a 1 to 2, it just means every second heartbeat is not fully inflated. It hasn't helped the patient at all. So that's important to address that and not to address the pump, address what's going on with the patient. Okay, so there you can see you've got an irregular heart rhythm. So we've got shorter, longer, shorter, very short, in between, and that's what your balloon would typically look like there. Right, so this is your hyper and hypovolemic. This is then directly related to preload. Again, something you'd need to address with the patient if you're observing this. Right, gas loss would be typically maybe something wrong with the actual catheter, or you may even have a catheter leak. You can see you've got a reduction coming along here. That's something that you can observe and address. We'll go through that now in terms of your troubleshooting. Kink in your catheter. We see this from time to time, more in an academic sector where the positioning of the catheter isn't correct or where the catheter has kinked. So remember we spoke about a relative contraindication on the balloon pump therapy if your patient has such severe PAD that the doctor may struggle with insertion. It can be that your positioning is incorrect or that the catheter with this very bad insertion has in fact kinked, and you are looking at this rounded curve that you see here, which isn't typical for the sharp V that we normally get with the balloon catheter when you look at its waveform on the console. And that just means that either your position is incorrect and the catheter isn't actually sitting in the correct position in the aorta, or it can actually mean that the catheter has kinked itself. And then you typically get that look. Okay, sustained inflation. Looks like that. Right, so now we're getting to complications in the balloon pump therapy, nursing care, the actual care of the patient that has got the balloon pump in situ. So important to look for. The number one complication of balloon pump therapy is limb ischemia. It's about 1% of all patients that receive a balloon catheter may struggle with limb ischemia. And so because of that, we actually equip each of our pumps with a Doppler. So that is something that should be checked hourly in terms of nursing care, or in the case of transport, the paramedics or the people that are looking after the patient that's being transported. So you need to be able to check your distal pulses, color, temperature, capillary refill hourly, and monitor your differential toe temperatures. And you would use a Doppler for this. So our pumps come equipped with this. And so we encourage that is done often. We don't want any amputations in any of our patients. And we haven't seen it for years, but it can happen. And that is still the number one complication of balloon pump therapy. It's one of the safest therapies out there. But if we don't check this, it can happen. So use your smallest sheath or catheter size available. So we went through the sizing that was available to us. Evaluate for risk factors. So this is more from the doctor or from an insertion side, understanding how at risk your patient is if you were going to use a balloon catheter for them, and selecting the limb with the best pulse. So it can be left or right femoral artery where we insert, and that is just from the doctor's side, selecting the right catheter size for the right patient. So if we are seeing that we are having distal limb perfusion issues, then these are the treatment options. Changing your insertion site or bypass graft the femoral artery insertion site. So these are if it's already happened. From you guys' side, from a prevention point, we want to be able to look at making sure that we are in fact looking for a pedal pulse all the time. Excessive bleeding from the insertion site. This may be more prevalent in terms of ECMO because of how much heparin you give your patients. So it is something that you need to keep in mind, and observing and checking for bleeding and hematoma formation at the insertion site. Okay, so your treatment options there are your pressure at the insertion site and surgical repair of the insertion site. It is something that you're going to be hyper aware of in any case if it is an ECMO patient. So thrombocytopenia, I think is even covered in ECMO as well. And that is really just because you've got something that's indwelling, that is moving. So we've got a catheter that's inflating and deflating with every heartbeat. So there is a possibility that that causes hemolysis and a breakdown of the red blood cells. I haven't myself seen it in balloon pump therapy as a rule, particularly because the majority of the balloon pump therapy that we are seeing is in patients that have the catheter in for 3, at most 5 days. Maybe a longer situation on a long ECMO, and it is something to keep in mind, although it isn't something that we see often. It is in any case something you guys are monitoring with an ECMO patient. So your platelets that you are giving and your assessment of platelets is something that you're doing on an ECMO patient anyway. Right, immobility of the balloon catheter is something that you need to be vigilant on. Balloon pump therapy, and in particular our pump consoles, tend to go into standby if there's an error of some kind. So if there is a disconnection of the catheter, the helium line becomes disconnected from the catheter. When we move the patient, the pump stops. And if the pump stops, therefore the catheter stops inflating and deflating. You will see on your console that you are on standby. And with troubleshooting and with errors, you need to make sure that you have addressed this so that you don't have an immobile catheter inside your patient for an extended period of time. Perhaps your risk is somewhat reduced in an ECMO patient because of the amount of heparin that you give your patients. But the big issue is that you don't want clot formation on the surface or on the substrate of the catheter itself. You can imagine if you've got a 50 cc catheter inside your patient that has now deflated, you've literally sucked that balloon flat. There's a whole bunch of folds inside that balloon, and you don't want any kind of clot formation forming there. So if you've now addressed whatever the problem is, but you've had this catheter immobile for, let's say, an hour, and you're now going to start the balloon again, then you run the risk of shooting a clot straight to the patient's brain because it's right in the aorta, centimeters away from the carotid. So that's very important that we are aware of any kind of troubleshooting or issue where your catheter isn't moving, that you run the risk of that. So your assessment and the observation of the movements of the catheter must be there, not allowing it to be in the patient immobile for longer than 30 minutes. Your console will warn you. The pump will warn, and it starts counting from a minute. So the minute you put the balloon catheter into standby for whatever reason, there's a counter that pops up on the screen and it tells you that the balloon isn't moving. And it will alarm, and it will continue to alarm to tell you that you need to address it, that there's a risk to the patient for that. Right, so if you consider that you have now had the catheter immobile for an excess of 30 minutes, it should be removed, and you need to then apply the necessary pressure at that insertion site. So if you're unable to inflate the balloon with the console and inflate and deflate by hand using a syringe and stopcock once every 5 minutes, I don't really recommend that. I recommend that the catheter comes out. Right, so balloon leak. That you will observe if you are actually seeing blood inside the lumen of the gas line. And that can be a little bit difficult to interpret as blood. So on ECMO patients, again, where you are going to be seeing some oozing and some bleeding, you need to clean that site quite thoroughly so that you can make a proper assessment. You're going to be seeing on oozing from the patient's insertion site, maybe some bright red blood. That's just oozing from the site. That isn't actually blood inside the inner lumen of the gas line. Blood inside the inner lumen of the gas line will present as flaky, dry, or even brown flecks of blood. So you may not even think it's blood at initial observation. And the reason why that looks that way is the helium inside the catheter or inside the gas line dries out the blood instantly. So the risk with that is if there is in fact a leak in the balloon, it's usually minuscule, and you've got small amounts of blood that are now collecting inside the balloon. And each time it comes into contact with the helium that inflates and deflates the balloon, that blood dries out, and then you're then looking at that entire, in a case of a 50 cc, that entire 50 cc eventually filling up and hardening. And there's absolutely no way you're going to be able to pull that catheter out as you would normally. That's a surgical cut down for that patient with a vascular surgeon's intervention, because you now have a 50 cc sausage, if you like, stuck in your patient's aorta. So those flecks and those observations of your line and of your catheter are extremely important that you do check that along with all of your observations often. And if you do observe that, that pump immediately goes into standby, balloon should be deflated. When it goes into standby, it does that automatically, and that catheter needs to come out. Right, so infection, we don't often see either, and I think that's because it's in an artery. So there's less infection that we see in artery sites than we do in vein sites, but it could happen, and it is a line and a catheter like anything else. So if lines and catheters need to be changed in a patient for whatever indication, then that should be done. So observe for signs of infection. You'd look at antibiotics and you'd change your lines like you would normally do. I haven't seen it though. And as I say, probably because balloon pump therapy tends to be shorter, doesn't tend to be months and months that the patient stays on the therapy anymore. All right, aortic dissection. This was one of the contraindications right in the beginning that we spoke about. So assess the patient for pain between shoulder blades and monitor your hematocrit daily. You guys aren't monitoring daily. You guys are monitoring all the time in terms of your hematocrit. And on ECMO, luckily, you actually have that indicator on your actual cardio help on your device itself, that you can see your HB and you can see your hematocrit. So you wouldn't need to observe that daily. You'd be looking at it anyway. So the prevention of this is that you should do the insertion of the balloon pump under fluoroscopy or under control, or at least you should check after insertion. So this would be a lesser indication for you guys that are transporting, because this would have been observed with insertion. Compartment syndrome is also something that we don't really see, but it is listed here as one of the contraindications, or one of the complications rather, that one should look for. Observing the limb where the insertion has taken place, and checking for any kind of swelling or edema. And that treatment would be if that has taken place for a fasciotomy for that patient. Again, we haven't seen this in many years. Right, the decreased renal perfusion, I think, is more relevant, because it is easier for that catheter to move, to migrate down, and to occlude the renals. So it is important that we are monitoring our fluid intake and output, and checking our urinary catheter. So again, that comes in terms of sizing of the balloon, your correct balloon sizing, and the position of the balloon catheter itself. And that's why in an ICU setting, we check every day to make sure that it is still in the correct position. Okay, so we spoke briefly, I spoke about the possibility of clots forming on the substrate of the balloon. and from leaving it in standby. Mentions here that the prevention is indeed anticoagulants, and that is in any case going to be the case with your ECMO therapy. So the management of the internal lumen that it mentions here, I think, is important. We don't, with the fiber optics, manage that internal lumen anymore. It's literally aspirated and flushed at insertion and capped. So it isn't something that the nursing staff in ICU regularly flush anymore. Right, so if your patient is awake and is aware, it's important that your patient understands the importance of that they can't move their legs or leg, and that they cannot sit up, that they may kink their catheter, and that you need to then prepare them for their limitations so that you have compliance and cooperation from them, and that you're keeping our patients safe and reducing anxiety. I've put in there the defib and resuscitate because it's a question that we often get. Do you have to switch the pump off if you are resuscitating, or if you do shock the patient? No, you don't. Just don't hold on to the console if you are in fact going to shock the patient, because it will shock you. So you don't need to switch off the pump if you are doing a resus, but you will find that the pump is going to alarm, and it is going to indicate that the augmentation isn't good and that the patient's blood pressure isn't good. And so all the triggers that it's looking for is problematic during a resus. But you don't need to switch off the console, and you don't need to stop it. Right, so the second line here on zeroing the transducers is only applicable if you're using a conventional balloon, which we don't use anymore in South Africa. We only use the fiber optics. And then this is just the general nursing care. So you're not elevating the patient more than 30 degrees, keeping the legs straight, assisting them with meals, etc., and the 4-hourly pressure care because they can't move, they have to be on their backs. It's just the general management and nursing care for the patient. Right, so now we get to the fun bit, and that is the CARDIOSAVE platform itself, so that you can see the transport unit. So we've got a 1-button to therapy here. It's literally as soon as the catheter is inside the patient. So that's maybe important if any of you are involved in insertion. Our balloons calibrate inside the patient, so we don't calibrate outside the patient. And it's just 1 button, and it does its own thing. So you can see here is a picture of the full console, and this is the transport unit that comes out of the console that you then put in ambulance or in helicopter or fixed wing ambulance. So I'm going to show you a few videos and on the transportation mode of the CARDIOSAVE. So I hope everyone can hear that.
So one of the features of the CARDIOSAVE hybrid is that it can convert into what they call a rescue model, and the rescue model then is a smaller transport unit that one can move into ambulance or aircraft. Right, so it's in order to move the components into rescue, one has to fiddle at the back and underneath the machine, which we'll show you. Then you'll notice that it's going to give you a message here on the screen, and then you need to detach the screen from its console here, and that then clips onto the smaller rescue unit. So we're just going to go through that process, and we're going to start by unclipping at the bottom, and I'm going to show you as we zoom in here where you're going to unclip. So put your machine's brakes on, or your console's brakes on, so that you are able to make changes without it slipping and sliding about. And you'll notice here that there's a little indicator here with an arrow to show you that this is where you unlock, and it's a clip that slides towards you forwards. Then the machine makes a noise, and you'll see that it will tell you that it is now in hybrid mode. Then you use this handle here, and it starts to slide out. This weighs 20 kilograms, so you'll likely need 2 hands. I also have a trainer that's plugged in here at the back, which makes it just a little bit more cumbersome for me, but we're going to go through it. Here's your second handle that you're going to grab hold of. That comes down onto the floor. Right. It's got a little clip with an arrow here. You zoom in and you can see that. If you push this arrow forwards, this pops up, and this is where your screen is going to mount onto. Now we're coming to the top of the machine, top of the console. And you will notice underneath the screen are two slide out clips underneath. And we're going to slide that off. Lift your screen off the console. And we're going to attach that now onto here. Right. Obviously this is inside our patient, and I'm going to take my little simulator with, otherwise I lose my patient in the process. Once you lift up your little pull handle here, you'll notice that the wheels pop out of the unit. Right, to put the rescue unit back inside the console so that it's back to the hybrid unit, you're going to drop down your handle, and once it's right down to the bottom, you'll notice that your wheels, which were out, slide back in. You're going to go with your screen again, releasing your clamps or your little clips on the side. You're going to attach that onto your console again. Right, so again, clip in here. You need to depress this, otherwise it's not going to slide back into the unit. And you've got your handle here and your handle here. Here, and you're going to lift that up. It goes here into your unit. Again, make sure that your brakes are on your console, otherwise you're going to have it sliding around. And you slide this in, you will hear a click. You will also hear the machine makes a noise, and it tells you that it's back into hybrid unit. Right, so one of the...
Right, so important to note in terms of the transporting is that the rescue module is running off batteries, and each battery at full charge can run for 90 minutes. And the unit runs with one battery at a time. So the CARDIOSAVE is equipped with 2 batteries, and it runs with 1 battery at a time, which allows you to hot swap the batteries. So charge one, use one. And you'll need an inverter in your ambulance in order to achieve that, because if it's not attached to its console, it isn't going to charge. So that's important to note. And your helium that is included inside the little reservoir tank, so it doesn't take its helium tank with it when it gets transported. So the helium reservoir inside is enough for 36 autofills. So in a stable patient, that can translate to 72 hours worth of therapy. In a wholly unstable, very sick patient, that might at worst translate to 10 to 12 hours worth of helium therapy. So that's important to keep in mind, that the machine continues to calibrate at every change in the patient's hemodynamics, or it calibrates every 2 hours in a stable patient. So those autofills that it speaks of there are used up in a very unstable patient. And in a stable patient, you've got a helium reservoir that can last for up to 3 days. Right, I am not going to, Mandy, you can maybe just jump in here. I see we've got time coming up here, so I don't think there's time for both of these videos. Do you want to go straight through to questions? This was really just a breakdown on the machine that you could just see front and back of it, but I think we've covered in terms of transport. Antoinette?
Okay, I don't know where Mandy went. I think.
Yeah.
Oh, okay. Are you saying something?
Are you finished, Samantha?
Yes.
I've got 2 more videos to still show, but I know that you cut off at an hour. And the other 2 videos were just to show the front and the back of the machine so that you could just get an idea on the functionality. But I can do questions if you prefer, or we can do the videos. I wanted to get your input.
I'd like to do a few questions, if there are.
Okay.
Is there anyone who would like to ask a question? If you can either raise your hand or unmute yourself. They're normally quite a compliant group, and if you've done a good lecture, they don't need to ask you too many questions. Are there anybody who didn't understand it? Was an excellent lecture. No, Samantha, I think you get off lightly on this one.
Okay, great. Did you want me to then show the videos on the rest of the machine?
No,
or
I
does it cut off?
think we can hold it there because we can hold it 1 hour. So
Okay.
anyway, I think we're over already by 2 minutes.
Yeah.
I just want to let everybody know that's been attending. Samantha, your calm way of presenting this just shows how knowledgeable you are and how
Thank you.
available you would be if there was a team that had to transfer a patient on ECMO and balloon or transfer a patient on balloon. So it's been a nice refresher for us that have worked in ICU a long time ago. So thank you very much. I didn't realize how much I didn't know, and I looked after many balloon pumps, patients on balloon pumps, and done some transfers on ECMO and balloons. It's been really good. Antoinette, thank you to you for agreeing to do the series. We are going to cancel the practical sessions until level 4 lockdown is taken away, and the reason for that is that if we did have a practical session, we would be breaking the level 4 lockdown regulation. There is one chat from Charlene Tronopol who says, thank you very much, and Lawrence who says, Samantha, great presentation and very interesting to know. So at this stage, it ends our ECMO training session. It's been a great series amidst a lot of problems with COVID, and people have been good at attending. I will get to the CPD certificates within the next couple of days. It's going to take me a while to collate everything. And I hope that you've learned. So please, the practical sessions are cancelled for now. We will inform everybody when the practical sessions can resume. And thanks to Leon, who every morning when we had a presentation, let everybody know. And to all of you that have joined for the past couple of weeks. Antoinette, thank you very much. Samantha, thank you very much. And every single one of you on the session. We really appreciate it. Have a safe day. KZN has not joined us today as they've had a particularly violent protest, and so they are a bit short-staffed. Be good, everybody, and be safe. Thank you.
Thank you, Mandy. Thanks, everyone.
Thank you.